Good morning, everybody, and let's begin our review of the blood system. And after that, we're going to complete from where we stopped last time. So we discussed that the circulatory system is composed of, who can remind us what's the difference between the circulatory system and the cardiovascular system. So, what is the cardiovascular system? The cardiovascular system. What does that mean? Cardiovascular system? Yes, please. Excellent. So, cardio is the heart, so it represents only the heart and as well as the blood vessels. And we said that these blood vessels are the conduits through which the blood fluid is passing. So if the blood vessels are the passageways that allow for the blood fluid to pass through them. What's the job of the heart? What's the function of the heart? So the heart function is to pump this fluid because this fluid is not moving by itself. Is air a fluid? Is air a fluid? What's a fluid? What is a fluid? A fluid represents gas like air or liquid like blood or water. Many students mix them up. They think fluid is a liquid. All liquids are fluids, but not all fluids are liquids. Your air is an example of a fluid. The air gas is a fluid. So now when we look at the fluid, thank you. Fluid is not moving from point A. Fluid is not going to move from point A to point B, except that the pressure P at point A is a lot higher than the pressure at point B. So, near my heart is the pump. So, my heart is pumping really hard. So, the pressure in the blood vessels near my heart is going to be high or low? It's going to be very high. What about the pressure near my toes? The blood vessels in my toes, is that going to be high or low? So the fluid is going to move from my heart to my toes, and then it's going to get pushed all the way around to return to the heart. So in fact, your heart, some aspect of it is connected to the highest pressure, the aorta, as we will see next lecture. And the other segment of your heart that is connected to the vena cava. Remember the superior vena cava and the inferior vena cava, those have the lowest blood pressure. And that's how we maintain a circle. That's why we call it a circulatory system, because it's a circuit of pressure gradient. There's a pressure gradient. So now when we look at this pressure gradient, the heart is our pump, and we have the blood vessels, but that's empty. The blood vessels are empty of blood. If you add to the heart, the pump, the blood vessels, the conduits, the tubes that the blood fluid is passing through, if you add to that blood, what does that now become? All of that. That becomes what system? That becomes what system if you have the cardiovascular system and you add to it blood? What does that become? Yeah, the circulatory system. Please remember this concept. Fluids. You will see also in the respiratory system that when you take a deep breath, air went inside your lungs. So air moved. What does the law say? The law says that air and any other fluid, air, liquid, water, blood, air is not moving except from an area of a high pressure to an area of a low pressure. When you take a deep breath, Air went in, so that means pressure was highest where? In the atmosphere or in your lung? Was pressure highest in the atmosphere or in the lungs? In the atmosphere. And then it was lowest in your lung. That's how air went inside your lungs. And when you exhale, so all the air is coming out your lungs. So the air is now moving from the lung into the atmosphere. Where was air pressure the highest when you're exhaling? Was it highest in your lung or was it higher in the atmosphere? In the lung. And then it went to the atmosphere. This law, we will see it in the circulatory system. Blood moves near my pump, my heart, to my toes where there is no blood. So now we have to now look at the immuno aspect of the blood system. And these are the blood types. You must remember that at the surface of your blood cells, of your red blood cells, at the surface of your red blood cells, I have this red blood cell. At the surface of this red blood cell, there are sugars that are unique to your blood, which makes your blood different from my blood. So we have sugars known as, we represent the first group as A. Then somebody else has a red blood cell, but on the surface, they don't have A. What do they have? They have blood type B. And another group, they have blood type O, which means that there is no A or B. This is very important. So now if you look at the immune system is sensitized to accept a particular sugar at the surface of the red blood cells. So my blood group, for example, is blood type A. So that means my immune system is doing surveillance. You know, like the cops are going patrolling. The cops are patrolling the neighborhoods and the streets. Your immune system, your white blood cells are patrolling your tissues and patrolling your blood and the intravascular compartment. Your immune system is patrolling and going inside the blood vessels, scanning the surface, scanning the surface of the red blood cells, scanning the surface of these red blood cells. If your immune system is sensitized to A, it will accept only blood cells that are type A. Let's say now you are type A, but they inject you and they infuse blood type B. What's going to happen now? Your immune system knows that we are A. So if we are A, your immune system will have anti-B antibodies, meaning that it doesn't want B. It can only accept A because that's who you are. You're blood type A. If you have B, you will not be accepted. So then that's why when you give somebody with blood type A, you give them B, their immune system is going to go around and say, what is that? Is this a red blood cell with type B? We are not type B, we are type A. So it's going to send those anti-B antibodies to destroy these red blood cells. That's very important to understand. Is that clear? So if you are of a one blood type, you do not accept, you do not tolerate the other blood type because you have antibodies. So if you are type B, you have anti-A. It means you don't accept A. If you're type B, you're anti-A. And if you're type A, you're anti. Does that make sense? If I am blood type A, my immune system is going to tolerate red blood cells type A and it will have anti-B. If you give me blood with a B red blood cells, it will destroy it. And vice versa. If I'm blood type B, the sugars on my surface or type B, my immune system will tolerate type B. But if you infuse blood type A, your immune system is going to mount an antibody attack with an anti A, because it is used to be, it is sensitized to B, it's against A. You must remember the difference between antigen and antibody. What's an antibody? An antibody is the actual weapon. The antibody is actually the weapon that your immune system uses to destroy the foreigners. So if you are type A and they infuse you with blood type B, then there will be antibodies against type B because you're type A. So these are antibodies. These are antibodies. These are antibodies. Now, what's the difference? You need to know the difference between an antibody and an antigen. What's the difference between an antibody and an antigen? An antibody, we just said, is the weapon that your immune system is going to use to destroy the red blood cells. Then what about the antigen? The antigen is what we are using to detect type A and type B. So antigen is everything at the surface of the cell that your immune system recognizes. Antigen is everything, meaning glycolipids, glycoproteins, glycocalyx. That is known as the antigen. So, for example, think about it this way. If you come into this school, you have an ID card. All students in the world have an ID card. But do they have the same ID card? Your ID is going to allow you to enter this school because this school recognizes this antigen. So your ID is your antigen. But if somebody else comes from another school with their ID, even though they have an ID, but it will not be accepted. So an antigen would be an ID. Everybody has an antigen. Everybody has an antigen. But do you have the antigen that allows you to be tolerated by the immune system? If your antigen allows you to be tolerated by the immune system, then you will pass. But if you have an antigen that is not tolerated by the immune system, then antibodies are going to be used to destroy that particular antigen. Is that clear? So the antigen here is A. A is the antigen. A is the antigen. B is the antigen. The antibody depends on your immune system. This is person B. Let's call this person B. This person is A. Person A has A antigen. Person A has A antigens. Person B has B antigens. Both of them have antigens. But the immune system of person B has anti-A antibodies because that's B, that's not A. And the person A has anti-B antibodies against B. It doesn't make sense that you are type A and your body has anti-A. It's going to end up destroying your own red blood cells. So you always have antibodies against antigens that are different from you. So antigens are complex molecules on the cell surface, and we said they represent glycoproteins, glycolipids, glycocalyx that are used to identify you, like an ID card. The collection of these glycolipids and glycoproteins at the surface of the cells represent, what do they represent? They represent your identity. No two people have the same glycocalyx, glycolipids, glycoproteins at the surface, except identical twins. Identical twins have no problem sharing blood. Identical twins have no problem donating kidney, donating a particular liver if they needed to. But the problem is, it has to be identical twins, not even fraternal. Fraternal twins cannot donate to each other. So if you take blood that is different from you, your immune system is going to destroy it. You plant a kidney, an organ, there's going to be a graft rejection. Why? Because the antigens are not your body unless you get them from an identical twin. Is that clear? Okay. ABO blood group. We alluded to that. We said that the blood has types AB, AB, and O. And these are determined by the presence or absence of the AB groups on the red blood cell. So now you really need to understand this. This is very, very, very important. So we already discussed the difference between antigen and antibody. Okay, this is type A. That means this person has type A antigen. This is person B. They have type B antigen. And this is person we call AB. And they have both A and B. And this is type O. They have neither. No A and no B. Now I need you to help me to tell what are, number one, the antigens. Antigen. What are the antigens? You have to help me determine the antigens. And you have to help me determine the antibodies. Okay, so if we look at the first person, type A, what are the antigens on person who has a blood group type A? Yes, please. Excellent. So the antigen here is A. What's the antibody? So who's the weapon going to target? B. So we call that anti-B. Does it make sense it has anti-A? If it has an anti-A, it's going to end up destroying its own self. Let's move on to person B. Person B has what antigen? In the back. Person B has what type of antigen? Person B has what type of antigen? B. And they have what kind of antibody? We don't call it A, we call it anti-A antibody. So if you're type A, you have anti-B antibody. If you're type B, you have anti-A antibody. Is that clear? Are we clear? What about a person who has both type A and B? What antigens do they have now? Excellent. They have type A and B. They have antigens A and B. What about antibodies? O means you have nothing. You're bare. You're bald. You don't have nothing. You don't have blonde hair. You don't have black hair, brown hair, red hair. You're bald. You don't have A. You don't have B. So you cannot have anti-O. Anti-O means you have anti-nothing. That's like having public safety that's supposed to prevent students who have ID cards for the university of nothing. So if you're O, you have nothing on the surface. Empty. So they don't have any antigen. Zero. So we call them O antigen. Zero. There's zero. Nothing in there. They have no antigens. Empty. 0%. Nothing. Nada. Zippo. So a person with AB, what kind of antigens are they going to have? Are they going to attack? Please don't tell me A, because if they have A, they're going to end up destroying their own self. Don't tell me B, they're going to destroy their own self also. So that means they have no antigens. Isn't that interesting? They have no antigens. Is that cool? No antibodies. Oops, they have no antibodies. Very good. They have no antibodies. If they have no antibodies, that makes them a universal receiver, because they could receive A, they're not going to destroy it. They could receive B, they're not going to destroy it. They could receive AB, they will not destroy it. They can receive O, they will not destroy it. So they are a universal recipient. We don't say receiver. The receiver is for the TV. Recipient. It's a universal recipient. Is that clear? They cannot afford to have any antibodies because they have both A and B. So that's why they can take blood from type A, blood from type B, or blood from type AB. Now look at blood type O. They don't have anything on the surface. However, what kind of antibodies do they have? They have antibodies against A because they don't have A. They only tolerate nothing. They don't need anything on their surface. They can only take blood from people who are just like them, that have nothing on the surface. So they have no antigens. They have no antigens, and they have A antibodies, so they will destroy anything that has a. They have anti-A antibodies, and they have anti-B antibodies. So that makes them a universal what? They're donors because they can give everybody blood. If you give blood type O to A, is A going to say, I have anti-O? What does O mean? O means nothing. So everybody tolerates O. So they are a universal donor. But unfortunately, they cannot be a recipient except from their own self. Universal donor. This is really, really, really important that you know that. The next part you have to know is that what happens, how do you tell if you have a blood sample? Let's say now I look into a blood sample and I have a mysterious blood here. I drop mysterious red blood here. I don't know. This blood could be what? It could be A, it could be B, it could be AB, it could be O. But I have all of my antis. I have anti A, and I have my anti B antibodies. I have my anti B antibodies, and I have my anti A antibodies. Is that clear? Let's say I take a drop of anti A and I drop it here in the middle, and it stays whole red. Nothing happens. Nothing changes. What does that mean? So this is type A. It means it's type B. This is anti. Please look. Anti means it will destroy that. If it's anti-A, it's anti-A. It will destroy A. Anti-B will destroy B. So if you take anti-A, you drop it on a mysterious blood, and nothing happens. The blood remains whole and red and nice looking and doesn't change. What does that mean? It means that that's type B because the anti-A couldn't touch it. But if you drop anti-B and you see the combat, and you see the blood starts to shred apart. You know, bad, have you seen bad milk? Have you seen milk go bad? You know, the blood can start to fall apart and collapse and get destroyed. When you put anti-B in a mysterious blood, then it starts to get shredded. That means the blood is what? If you put anti-B in this blood, then you see the blood starts to clump up and glue up like glue. Starts to clump up like glue, which is known as agglutination. Agglutination. Agglutination means the antibodies are, like, you know, the blood clot, they are clogging together all the red blood cells and clumping them together and destroying them. So if you drop that in there and agglutination happens, that means if you drop anti-B, everybody, can I have your attention please? If you put anti-B in this solution and you see that the blood is fragmenting, falling apart, and you have agglutination, what is that blood type? That is type B, because the antibody was anti-B. It could also be type AB, remember? Right? It can also be type B, because so then we will see now how to tell. So if you look here, so we went over that. Antigen is what's on the surface, A or B or AB. Blood type O has neither A or B antigens. AB person has both A and B antigens. Okay, if you examine, this, that shows you the actual. So you know we have a nice uniform name, type O, type A, type B, type AB. But actually the sugars are galactose, fucose, and N-acetyl galactosamine. So the way they are arranged, so if you look at type O, you have one of each. You look at type B, you have double of the galactose. You look at type AB, it looks like that. So those are not the same. Your immune system is looking for these. What do we call those? Blue, yellow, red at the surface. What do we name those? What do we call those? Antigens. Very good. So those are the antigens. And who's gonna, your immune system, if you're type B, is gonna have antigens against A. So if there's any A around, it's gonna destroy it. So we talked about that. Anti-A is gonna destroy antigen A. Anti-B is gonna bind to antigen B. And this is the agglutination. So if you are different, the antibodies are going to glue you up, make like a glue. They're going to agglutinate you and they're going to stick you up together. This is how we tell if the person is type A or B. So this is the blood, type O. I could hide this. I could hide type O, type A, type B, type AB, and you should be able to tell. Because all you need to know is that this is anti-A antibody, this is anti-B antibody. So now let's take type O blood. We drop type O blood here, we drop type O blood there. Then you drop anti-A. Does O have any A on the surface? So what happens to the blood? It's not affected. If you drop type O in an anti-B, what happens? It's still whole, unaffected. Now let's look at type A. What's on the surface of type A? What is on the surface of type A? Which antigens are found on the surface of type A blood? A. Which serum is that? That is anti. So when you drop blood type A in an anti-A serum, what's going to happen to it? Yeah, so what word do we say for going to get destroyed by the antibodies? What word do we say for that? Ag. Agglutination. You see here? That is agglutination, the agglutination of red blood cells. Now, when you drop type A in anti-B, will it be affected? Will type A dropped in anti-B, will it be affected? It will not, because because anti-B only target B. Let's look at type B. Dropping type B in anti-A, will it affect it? It will not. Dropping type B in anti-B now, will it cause agglutination? Do you see the agglutination? If you drop type AB in anti-A, will it be affected? Will it be affected? Yes, because anti-A is going to destroy the A component. It's going to say, yeah, I know you have B on you, but you do still also have A. So it's going to get destroyed also. What if you give somebody who has blood type B, you give them AB? It will say, even though you have B just like us, but you still have A. So it will destroy it. Does that make sense? So this is what happens in the mismatch of the graft rejection or the transfusion reaction. When you give somebody a different type of blood, you give them when you give somebody a blood type that is a different antigen than what their immune system is used to, that's going to cause, what's the name of the reaction that's going to happen? What's the name of it? Agglutination. Very good. So do you see agglutination here? Can you see agglutination here? You see this clumping? What is agglutination? From the word glue, they are glued up. So agglutination means that they are getting glued up, and they are clumping and sticking together. Is that clear? Questions? Any questions? So that person is a type B. This person here, look, it tells you type B person. If it tells you type B, do they need to tell you it has anti-A? You can know. You don't need to tell you, because you already know. If I'm A, I'm anti-B. If I am B, then I'm anti-A. If you have a U.S. passport in the airport in the U.S., are they going to be anti-U.S.? No, they're going to be anti-foreigner, because you don't have the U.S. passport. But if you take the U.S. passport and you go to another country, are they going to be anti-you? Absolutely, because you're a foreigner now. So that person is type B. So are they anti-A or anti-B? They are anti-A. So they gave them blood from a type A donor. So receiving blood from a type A donor, that's going to cause this clumping and this agglutination. Type O is very interesting because it has no sugars at the surface. Now, if you recall, we don't just say type A, we don't just say type B, we say A positive, A negative, AB positive, AB negative, O positive, O negative. What's positive, negative? Positive charge, electron. There's an electron on the red blood cell. The red blood cell is a cation now, it has a plus charge. What's the plus? What's that all about? Okay, so this is known as the rhesus factor. This is a convention known as the RH. This is the RH. RH stands for rhesus factor. What does rhesus factor do? What happens is, this is the mom. When the mom is pregnant with a baby, this is the mom. That's her hair. This is the mom's hair. Okay? And the mom is pregnant with a baby. This is the baby. You know the baby cannot breathe air. The baby still relies on the mom for breathing. So when you're pregnant, When your mom was pregnant with you, or when you become a mom and you become pregnant, when you take a deep breath, what happens? You're breathing for both, for your blood and for the blood of the baby, because the baby doesn't have access to air. Does the baby have a tube that goes and connects them to the air? It doesn't. So the baby sends their blood through the placenta to mommy, and mommy breathes for them, inhales for them oxygen, and exhales their carbon dioxide out. But the problem is that baby did not only come from mom. That baby also had genetics with dad. So now what happens is this mixture is going to give us the following. So if the mom is on her red blood cell, so this is let's now look at mom versus baby. Let's look at the blood of the mom and the blood of the baby. Let us now examine the blood of the mother versus the blood of the baby. So when we look now, we have mother, obviously pregnant mother, and we have baby. So at the surface of the mom, if the mom has RH on her surface, if the mom is RH positive, is she gonna have antibodies against RH negative? What is the mom gonna have? The mom, this is what is RH positive? That's an antibody or antigen? That's an antigen. Everything on the surface is a sugar, type A, type B, RH. That's a sugar. That's an antigen. Always, if you're on the surface of the red blood cell, if you're on the surface of the red blood cell, that makes you an antigen. That makes you an antigen. That makes you an antigen. So the mom now has an RH positive antigen. The mom has an RH positive antigen. What kind of antibody does the mom have? RH speaking. Does the mom have RH antibodies? Will she have an RH antibody? She has an antigen. Will she have an antibody? She will not. If the mom has an anti-RH, if she has an anti-RH antibody, what does that mean? Imagine the mom has an anti-RH plus. What is that going to lead to? She's going to destroy her own blood. She cannot breathe now because she has no red blood cells. She's destroying her own blood. So it absolutely makes no sense that the mom will have an RH plus. Is that clear? Now let's say there is another mom. There is another mom. She has her nice red blood cells, but she has no RH. Empty. So what do we call that? Not O. We call it RH minus this time. RH minus. RH minus. What does RH minus mean? It means she has no RH. It's like a O, exactly, but we just don't call it O because O was taken by, remember, the galactoses and the fucoses, but the same concept. Now let's say both moms get pregnant. The RH plus mom, the RH plus mom, and the RH minus mom. Let's say they both got pregnant and they both have a baby. Let's look at their immune response. If the mom who is RH plus is pregnant with a baby who is RH plus also, right? What can the baby be? The baby can either be RH plus or the baby can be RH minus. These are the two possibilities. As a baby, what can you become? You can either be Rh plus or Rh minus. True or false? Guys, please listen up. A mom who is Rh plus, she's pregnant with a baby. This baby can have either two kinds of red blood cell. The red blood cell is either Rh positive, meaning that it has an antigen who is Rh positive on the surface of the baby, red blood cell, or the baby is going to have no Rh. So let's look at both scenarios. If the mom is Rh positive, does she have a anti-Rh against the Rh plus? Does she gonna have an antibody? Will the mom who is Rh plus have an anti-Rh plus? It will not. So that baby will be delivered safely. The baby is gonna be born in the baby shower. Now let's look at this one. If the baby is Rh minus, the baby has no Rh. Does the mom have anti-Rh minus? No, because there is no RH. We just call it RH minus, but it really is O. Just like O, we call it O. Does O have an O on the outside? O means nothing. It means empty. So RH minus, the only reason I write it like that, RH minus, for you to know, but really there's nothing, is empty. Is she going to have an anti-empty? So now everybody is delivered safely. Everybody is delivered safely in a baby shower. So the best mom is the mom who is what? Rh positive. So every mom now has to get the injection when she's pregnant to become Rh plus. Because now let's look what happens when she's Rh minus. Now, the mom is now Rh minus. The mom has no Rh on the surface. So what are the two possibilities? The first possibility is the baby is Rh plus and the baby is Rh plus, or the baby is Rh what? Minus. Now let's look at Rh minus. Let's begin with Rh minus. The mom is Rh minus. The baby is also Rh minus. Is there any problem? This baby is gonna be delivered safely. Now, look, if the mom is Rh minus, is she going to have an antibody against plus? Absolutely, because she doesn't know what that is. On her surface, I'm empty. Baby, my red blood cells are empty. You're bringing now from your father genetic side, your mom, your father, mom, the mother-in-law, and the father-in-law, and that section of the family, you're bringing in something I never saw before, this Rh plus. So she will have an anti Rh plus. Now that baby now, the immune system of the mom is going to send say it with me, anti-Rh plus antibodies. And she will destroy the red blood cell of the baby who is Rh. And the baby will die. Actually, something very interesting. If this happens on the first pregnancy, the baby does not die. God give the baby one chance. So the baby is born. But next time, if the mom is again pregnant with another baby and she's Rh minus and Rh plus, the antibodies, the memory cells, they're going to say, we remember that. We tolerated that last time. We were informed. Imagine, somebody leaks into the school, a criminal, the homeless criminal walking to the school, and they made it the first time. Now the whole public safety is so alarmed. If another one tries to walk in the next day, are they going to allow it? That's exactly what happens. In the first pregnancy, the antibodies for the Rh plus are not yet made. So they are going to be made first. The next pregnancy, if the mom is Rh minus, but the baby is Rh plus, the mom immune system She didn't kill the baby, but her immune system, not knowing, it has no way of knowing that that's the red blood cell of the baby. She will assume, oh, you're different, then that means you're a foreigner. Is that clear? So every mom must get a shot. What's the name of the shot? Rogam. Rogam. What's the name of this shot? If a mom gets this shot, she will become Rh positive. So every mom got to get that shot. Yeah, that's good. We want you to be Rh. So now it doesn't matter if the baby is Rh, the baby will survive because you don't have anti-Rh. And if the baby is Rh minus, it's not going to survive. The problem is if you're Rh minus and the baby is Rh plus, you're going to kill that baby. So if you're Rh minus, you could change your blood type. Absolutely. With the shot. You don't change the blood type. You change the blood type from Rh minus to Rh plus. So now you see what plus A positive means. You are blood type A and you are Rh positive. A minus means you're blood type A and you're Rh negative. So the baby is not the problem. The baby can be Rh minus Rh plus. The problem is the mom. She's the one who needs to be always Rh what? Positive. Is that clear? This is really, really, really important. So what's the name of the reaction that happens? We don't call it agglutination no more. Agglutination is when they all clump up. Then they all gonna get clumped up, and the baby blood cells are gonna get clumped up, and they're gonna get destroyed. And this is known as the maternal fetal mismatch. This is the lytic destruction. That's the destruction of the blood cells of the baby due to the immune system of the mom. There we go. Everybody, please look at this figure. This figure is very important. The first pregnancy, you see, you get a second chance. The first pregnancy, the mom is Rh minus. That's the problem, mom. When she's Rh minus, she didn't get the shot. She didn't get Rogam. Then the Rh, the mom is gonna have no tolerance for the Rh antigen. The baby is Rh plus. So now you see the green antibodies are made. So those antibodies are gonna say, oh, last pregnancy, an Rh antigen made it through, and we need to wake up now. Now they woke up. In the second pregnancy, you have the antibodies. If another child now is Rh plus, then the mom is going to have those antibodies against it. But if you get the Rogam shot, are there going to be any more antibodies? They're not going to be any more. Clear? And we're done with red blood cells. Any questions? Yeah. It is not a problem, the baby. Remember, it's not a problem, the baby. The problem is the mom. So the baby can be minus. It could be twin baby. It could be triplet. You know, one lady had the 9 babies at one time. It was on the news. You could be anything. The mom is the one who kills. Her immune system is the one who kills. So we need to be safe. Getting one shot that makes your blood Rh positive is not a big deal. Now you're safe. If the baby is Rh minus, you have no antibodies against it. If the baby is Rh plus, you have no antibodies against it either, because that's you now converted your whole. You converted your whole blood to Rh plus. Okay? Good God, we're done with red blood cells. So now we're gonna move into the white blood cell. White blood cells, these are the cops. These are the police. White blood cells are the cops, the police officers. The white blood cells are responsible for combat. White blood cells are responsible for combat. You know, you guys need to remember EPO. What did we say about EPO last lecture? This is really important. You know, remember the template we went over? Remember, I even did that in Biolab. You guys remember when we did the template for homeostasis? That if you have homeostasis, what do you begin with? If you have homeostasis, you begin with. If you have homeostasis, You begin with a sensor. True or false? You begin with a sensor. Are we true or false? Who is the sensor? Who is the sensor? Who remembers the sensor? The sensor is a receptor. The sensor is a receptor. The receptor is either a photoreceptor, a chemoreceptor, a mechanoreceptor, an osmoreceptor, thermoreceptor, all kinds of receptors. But he or she, the receptors, are the ones who will tell me if there's a hyper or hypo. Let's see now. Let's say now, I live up in the mountain, or I smoke nicotine or cannabis, or I have blood hemorrhage. What happens now? This is hypo or hyperoxemia. That's hypo. So there's a drop. There is a drop minus. There is a hypoxemia. Hypoxemia. That's the sensor is gonna detect that. What kind of sensor is that? Mechanoreceptor, chemoreceptor, osmoreceptor? That's not a mechanoreceptor. Mechano doesn't detect oxygen. Oxygen is a chemical, so that's a chemoreceptor. So the chemoreceptor is gonna send what? An input, sensory, afferent or efferent? Input, sensory, afferent stimulation. It's gonna go to a integration processing and control center. Are we clear? This processing and control center is going to process the problem. Who's going to process that the blood level went down and dropped? Who's responsible for that? Yeah, very good. So the kidneys and also the liver. They're going to detect that oxygen drop. Then they're going to generate what? An output that is motor and efferent. And since it's efferent, it's going where? To the efferent is going where? To the effector. To the effector. To the effector. Are we clear? Questions? Questions. To the effector. Is that clear? Effector. Who's the effector now? Yeah, the red bone marrow. So we're going to go inside the bones, in the red bone marrow. And the red bone marrow, what was the hormone that stimulated the red bone marrow to make a lot of red blood cells, to replenish the supply of this red blood cell that was lost in the hypoxemia? What's the name of the EPO? EPO stands for erythropoietin. EPO. Erythropoietin. This erythropoietin is going to cause an increase in red blood cell production. So that's going to restore the amount of red blood cells. Can somebody please tell me why is it dangerous when somebody smokes cigarette as far as blood clots, or somebody that has emphysema or COPD, somebody that has emphysema, COPD, or asthma, or smoke severe asthma, or smoke cigarette or cannabis, how do they end up with really thick blood when they go to do the blood work in the doctor's office, when they take a blood sample. Remember last week we said that those juveniles under 18 smoking the cigarette in the toilet, and when they go to the doctor, they take their blood work and their blood is hypercoagulable. Why was that? What was the reason for that? Yes. The body makes excess red blood cells. Why did it do that? Excellent, very good. Because the oxygen is there, but hemoglobin is not unloading it because nicotine is blocking it, because cannabis is blocking it, because emphysema is not allowing for the gas exchange. So the red bone marrow says, maybe because we don't have enough red blood cells, let me make more red blood cells. Let me make more red blood cells until the blood becomes really thick, causing blood clots. That's as far as red blood cell. If you look at the white blood cells are known as what? What are white blood cells also known as? Yeah. White blood cells are known as leukocytes. White blood cells are known as leukocytes. WBCs, these are known as leukocytes. These white blood cells, they were actually stem cells. They were stem cells. These white blood cells are stem cells. These white blood cells are stems, in the beginning are stem cells. But you have to remember, all red blood cells are the same, but are all white blood cells the same? All red blood cells are the same because all they need to do is carry oxygen and bring back carbon dioxide. Like the subway cars. When you get in the subway, are they that different? Because they just got to transport people and bring them back. Now, when you look at the white blood cells, they're not different. You have white blood cells that need to become neutrophils, and neutrophils destroy bacteria. Neutrophils destroy who? Bacteria. Eosinophils. Eosinophils destroy who? Parasites. Parasites. And fungi. Parasites and fungi and viruses. Lastly, you have basophils. And basophils are very important because they target a specific classes of viruses and some worms, helminthes. So now you see you have three classes, but the stem cell is the same. So how, let's say I get a bacterial infection, my friend gets a parasitic infection. We start from the same stem cell. The type of bacteria is going to cause us to differentiate. Differentiate. So you're going to differentiate into a neutrophil, differentiate into a eosinophil, differentiate into a basophil based on the need. Remember we said how much percent is the creamy, yellowish, buffy coat in our all blood? That's 1%. And we said it's actually good for it to be that low. Why is it good for our white blood cells to always be low? Very good. So that means your body is not fighting an infection. Like I said, you walk into the school, you see 3 public safety officers walking around. Does that sound alarming or worrying. But if you see 1,000 of them running around, what are you going to think now? You're going to think there's a problem. So when you do your complete blood count, your CBC, and you see your neutrophils are through the roof, what does that mean now? It means that you're undergoing what kind of infection? Bacterial infection. So now you have to know that these leukocytes, white blood cells, are full of granules. Granules. These granules are full of weapons. These granules are lysosomal enzymes. Degradative enzymes. Lysosomal enzymes, the degradative enzymes, metalloproteinases. Lysosomal enzymes, the degradative enzymes, metalloproteinases. There's also burning acid. You know, acid is going to burn bacteria. There's also reactive oxidative species. All of these are weapons to destroy all the infectious microbes inside a granule. So if you look now, you will see that this is the white blood cell. It has a nucleus and it has lysosomes. You must remember the lysosomes. Lysosomes are full of these lysosomal enzymes, these very dangerous hydrolytic enzymes, degradative enzymes, lysosomal enzymes that once the white blood cell swallow, phagocytize. When the white blood cell phagocytosis. What does phago mean? Yeah, eat. Very good. And cytosis is this, the white blood cell eats those microbes, eats those neutrophil, the neutrophil eats those bacteria, eats those viruses, eats those lymphocytes. Are we clear? Granulocytes, they have granules, and these, number one, are the neutrophils, and they are the vast majority of white blood cells are the neutrophils, 60 to 70%. And they are specialized only to fight who? Aggressively antibacterial. They are bactericidal. They destroy and they kill bacteria. So whenever there is a bacterial attack, who do you expect number to rise? The neutrophil. What do we call the increase in the number of neutrophils? Neutrophilia. Neutrophilia. Eosinophils. Eosinophils are large, rosy, orange granules. So their number fluctuates greatly from day to night and seasonally with the phase of the menstrual cycle. So the numbers are going to increase in this eosinophilia in parasitic infections, allergies, collagen diseases, and diseases of the spleen and the central nervous system. So they phagocytose the antigen, and there is a antigen antibody complex. You remember that those eosinophils do they deal with bacteria? Who deals with bacteria? Neutrophils. You see, everybody look here. So neutrophils aggressively antibacterial. Those are the neutrophils. They are aggressively antibacterial. But if you look here in the eosinophils, they are what? The eosinophils are antibacterial or parasite. Parasites, allergies, collagen diseases, and so on. Basophils. Basophils, they are coarse, dark violet granules, and their numbers increase in chickenpox and sinusitis, like a viral disease. They increase with viruses. It's a neutrophil. So remember that a neutrophil has 3 to 5 lobes. You see, neutrophil has 1, 2, 3 to 5 lobes. How many lobes does the eosinophil have? It's bilobed. Looks like a kidney. You see, bilobe. That's the eosinophil. And the basophil has a S or a U-shaped nucleus. It's a S or a U-shaped nucleus. So those were the granules. Neutrophils have granules, basophils have granules, and what's the last one? Neutrophils, basophils, and eosinophils. Is that true? Now there is another class of white blood cells known as the agranulocytes. Known as the agranulocytes. And these are the lymphocytes and the monocytes. Lymphocytes, they have variable amounts of this bluish cytoplasm, and their numbers increase in diverse infections and immune responses, and they destroy cancer, foreign, and virally infected cells, and they secrete antibodies and they provide immune memory. Monocytes differentiate into macrophages. Monocytes differentiate into macrophages. So these monocytes are going to be circulating in a dormant, inactive shape. In a dormant, inactive shape. Once they encounter an invader, they will convert from monocyte to what? Okay, so when we look at the monocytes, so inside, what did we say that blood vessel cells are known as? What's the name of all the, we said blood vessel cells are not made of plastic. What are they made up of? What are blood vessel cells made up of? What are blood vessel cells made up of? What's the name of the cells? Excellent. These are endothelial cells. So inside the blood, you will have monocytes. Monocytes. And out here in the tissue, this is the tissue compartment. That's the tissue. These are the nucleus. Those are the cells. Let's say there's an infection now. There's an infection, bacteria, virus, cells are damaged. There's a problem here. These monocytes are going to have to squeeze out. So these endothelial cells are going to retract. They're going to move backward, are going to retract and move backward to allow for a gap. What is this gap called? This gap is called interendothelial gap. Interendothelial gap. And through this gap, who gets out now? Who gets out? Who gets out now? The monocyte. And when the monocyte arrives to the tissue, it changes. It converts from monocyte into what? That's very important. Monocytes differentiate. Remember the Pokemons? One Pokemon is going to evolve into another thing. But here we don't call it evolve. We call it proliferation. We call it differentiation. So monocytes, when they encounter a microbial infectious invader, what do they convert from monocytes to? They convert from monocytes into macrophages. Very good. They go from monocytes into macrophages. Very good. So there you go. They leave, you see where my mouse is? They leave the bloodstream and they transform into macrophages. So remember, these are agranulocytes. They have no granules. They have no lysosomal enzymes, hydrolytic enzymes. The leukocytes has a very interesting life history. The granulocytes live in about 4 to 8 hours, and they live 4 to 5 days. The monocytes takes them 20 hours, but they transform or differentiate or proliferate and live for few years. You see, this is the figure I drew for you. In this figure, we have stem cells. We have stem cells. These stem cells can convert into colony stimulating units. So, for example, if you look at the end mature product, if you look at the end product, eosinophils, basophils, and neutrophils, those three, what do we call them? What do we call eosinophils, basophils, and neutrophils? Granulocytes. Very good. And what do we call monocytes and lymphocytes? Agranulocytes. Let's say I get an infection that requires neutrophils. So we go from hematopoietic stem cell and it will differentiate into neutrophils. But if I have a hematopoietic stem cell, I need it to become a B lymphocyte. It will take each arrow represents a lineage. So there is a cytokine, a chemical that's going to stimulate the stem cell to commit to a particular track. So this track here, if you commit to this track from the stem cell, you're going to end up becoming a eosinophil. If you commit to this track as a stem cell, you're going to differentiate into a basophil. What is leukopenia? Leukopenia is when we have a low white blood cell count. Same thing, neutropenia is when you have a severe drop in neutrophils. Leukocytosis is when there is high white blood cell count, above 10,000 white blood cells. So leukemia is when you have leukocytosis and severe increase in white blood cells. So that's cancer of the hematopoietic tissue, usually producing a very high number of circulating leukocytes. So there are different types of leukemia. There's myeloid leukemia, lymphoid leukemia, acute leukemia, and chronic leukemia. Myeloid leukemia is when you have a severe granulocyte production, because the granulocytes come from the myeloid, you see the myeloblast, from the myeloid lineage. But from the lymphoid lineage, you have the B lymphocytes and the T lymphocytes, and lastly, the natural killer cells. So lymphoid leukemia, uncontrolled lymphocytic or monocyte production. Acute leukemia appears suddenly and progress rapidly, and the death is within few months. Chronic leukemia is undetected, but the survival time is about 3 years. This is normal blood and leukemic blood. So now we're going to talk about the platelets. Platelets are important. What did we say platelets are also known as? Yeah, platelets, excellent. Platelets are also known as thrombocytes. And they act like what? Band-aids. They act like band-aids. What's the function of the platelets? They are responsible for what? What are platelets responsible for? Yeah, they are responsible for stopping the bleeding, and they are responsible for ensuring that we don't have blood loss. We don't have permanent blood loss. So these platelets are band-aids, and you see they are fragments. So everybody please look here. You see these platelets? They are so tiny circles. Those tiny circles are coming from where? Are coming from this really big, very huge cell known as the mega, not maga, mega karyocytes. So the mega karyocytes give us fragments that end up becoming the platelets. Very good. So if erythropoiesis means the making of red blood cells, and leukopoiesis means the making of white blood cells, and thrombopoiesis means the making of the platelets or the thrombocytes. So thrombopoietin, just like erythropoietin, thrombopoietin triggers stem cells to become megakaryoblast. So we go from megakaryoblast, these are the large cells with multilobule nucleus, and they are the ones that give us the proplatelets, and from proplatelets we get the platelets. So now we're going to discuss hemostasis, hemodynamics, and hemostasis. What's the difference between hemodynamics and the hemostasis? What's the difference between hemodynamics and hemostasis? We have hemodynamics and hemostasis. Hemo means what? What does hemo mean? Hemo means blood. Hemo means blood. Stasis means what? Dynamic. What does dynamic mean? Dynamic means, what does dynamic mean? Dynamic means movement, dynamic, moving. The universe is dynamic. If you look in a telescope, the stars are just stopping in there, like the stars that you have on your ceiling in your bedroom. They're just like stopped there. It's like a projection. No, the stars are moving, so it's dynamic. Your plasma membrane is dynamic, is moving. The channels are moving. Phospholipids are moving. Enzymes are operating. In the cytoplasm is moving. Organelles are moving. Mitochondria is moving. Golgi body is moving. Nucleus is also dynamic with a lot of movement of transcription and replication. So dynamics is moving. Hemostasis, stasis means what? Stationary, stop. So people who have high blood thickness, high blood viscosity, are they in a state of hemodynamic or hemostatic? So the blood is really stopped. Okay? So now when we look at a gunshot wound, if somebody gets shot by a gun, or if there's a stab wound, what's going to happen? Blood is going to get lost. So your natural bodily reaction is to do what? Is to bring the band-aids. Who are the band-aids of your body? The platelets. So we need the band-aids, number one. Number two, what do we need to do to the blood vessels? We need to squeeze them to prevent them from, let's say you have a water hose and the water hose leaks water. What are you going to do to it? You're going to tie it to close it to prevent that the water is going to flow out of it. So we don't want the blood to flow out of the blood vessel, so we do spasm, vascular spasm. Vascular what? spasm. So now when you look at the vascular spasm, that's the first step. So hemostasis is a triangle. There is a triangle of hemostasis. If you want to achieve hemostasis after blood loss due to a gunshot wound or an injury, the first step is vascular spasm. You want to ensure that this blood vessel is locked. So there's prompt constriction of a broken vessel. That's the most immediate protection against the blood loss. That's the first one in the triangle. The first part of the triangle is vascular spasm. Number two, the most immediate protection, it provides most immediate protection against blood loss, and it provides time for other clotting pathways to happen. So nociceptors, what are nociceptors? You guys did that last semester. What's nociceptor? Nociceptors are, noceo means pain. These are the pain receptors. So the platelets release serotonin. That's a vasoconstrictor. So look at the first step, vascular spasm. Does everybody see the vascular spasm? The twisting of the blood vessel to prevent blood loss. Then you have the platelet plug formation. Platelet plug formation is when we recruit the platelets. So that's the second step. The second step is platelet plug formation. Coagulation is when the blood clots come together. The blood clots come together to block the exit side of the red blood cell. So that is known as coagulation. Coagulation means the blood viscosity is going to increase. So is it in our best interest that when we are injured and we are losing blood, for our blood to become really thick or really thin? Really thick, to make its movement slower so we don't lose a lot of blood. So coagulation is the last and most effective defense against bleeding. It has the conversion of plasma protein fibrinogen into soluble fibrin. So these fibrin threads are going to hold together this blood clot. I told you earlier that whenever you have nogen, fibrinogen, pepsinogen, trypsinogen, angiotensinogen, you heard of those, inogen. If you end with nogen, it means you're inactive. So fibrinogen is inactive. So that means we convert it by removing the nogen out. What does fibrinogen become? Fibrin. Fibrin now is like a meshwork that's gonna bring together, is a meshwork that is going to tie and bring together all of the red blood cells. So these are the pathways for coagulation. What's the difference between an intrinsic and an extrinsic pathway? Why did they call a coagulation pathway an intrinsic pathway? And why did they call the extrinsic mechanism a extrinsic pathway? Why did they do that? Intrinsic means you're bleeding from the inside, internally, intrinsic. Extrinsic means you're bleeding from there's an injury on the outside. That's why they put for you here like some sort of stick or something that pricks the skin. But in the end, whether you trigger an intrinsic mechanism or an extrinsic mechanism, both of them have different steps, but in the end, they're going to have a common pathway. What's the common pathway? The common pathway is factor 10. So from factor 10 and onward, you're going to see different events. Number one, converting, everybody look. If you end with nogen, it means you're inactive. That's a suffix, Nogen means inactive. There's another prefix that means you're inactive, like a pro something. Pro insulin. Even in this lecture today, we went over platelets. What are they? Proplatelets. Proplatelets. You see where my mouse is? Proplatelets. Proplatelets. Pro meaning you're immature. Unlike I would say the pro meaning like you're professional. But no, over there pro means you're immature. You're getting training. So if you begin with pro, it means you're really weak. You're really young. So you have prothrombin is going to be converted into thrombin. Thrombin means a big blood clot. Then thrombin is an enzyme that's going to convert fibrinogen into what are we converting? We're converting fibrinogen into, it's in there. Thrombin is an enzyme that's going to convert fibrinogen into fibrin. And then fibrin is the one who's responsible for initiating the fibrin polymer. So you must remember that the extrinsic pathway and the intrinsic pathway are different successive steps, like dominoes effect. This one activate the next one. But both of them, either you're bleeding from the inside, internal hemorrhage, intrinsic mechanism, or you're bleeding on the outside, extrinsic mechanism, external hemorrhage. In the end, you have to convert in the common pathway, which is activation of factor 10. Factor 10 is going to activate prothrombin activator. Prothrombin activator is going to activate prothrombin into thrombin. And thrombin is going to activate fibrinogen, do like a little surgery to fibrinogen, remove the inogen out, and leave you with active fibrin. And fibrin is going to cause the threads and the meshwork. You see this brown stuff? See this brown stuff that is holding together all the red blood cells? That's fibrin. So that's the cascade that begins from factor 12. Then we end up here. That's the common pathway. Then you have prothrombin activator, converting prothrombin into thrombin, then thrombin converting fibrinogen into fibrin, then fibrin goes and makes a meshwork of red blood cells. So to complete the coagulation, there is a process known as clot retraction. So here the platelet pseudopods are going to adhere to the fibrin meshwork and they're going to contract, and the clot is going to become so thick and tight within 30 minutes to prevent blood loss, to successfully, like a band-aid, prevent blood loss. The overall efficiency can be measured with the bleeding time. So they used to have a primitive test where they make like a little prick and they see how fast it takes your platelets to stop the bleeding. They don't do that no more, but that was how they used to measure how effective and efficient your platelets in stopping the bleeding. So now the blood clots, are they going to be there forever? Is the band-aid going to be there forever? Once the blood vessel is healed, when we have a healing of the red blood vessel, and the blood vessel now is corrected, no more hemorrhage, no more blood loss, no more trauma, do we need platelets anymore? No, we need to remove them now. So the tissue repair begins. We have the platelet-derived growth factor. That's a very important growth factor, PDGF. It is secreted by the platelets and the endothelial cells and stimulates the mitosis. It's a mitotic stimulant for the fibroblast. Fibroblasts are when you heal by scar, when there's a scar. Have you ever been injured and then you saw a scar form there? So that scar is because of the fibroblast. The fibroblast makes a scar. Fibroblast makes a scar tissue. The fibroblast makes a scar tissue. Now, if we want to dissolve these platelets, do we make more fibrin or we need fibrinolysis? We need to lyse this fibrin meshwork now. So that's the dissolution, dissolving of the clot. And that occurs after the tissue repair is complete. And factor 12 is going to make for us an enzyme known as kallikrein. That's very important to know. Kallikrein or kallikrein. Kallikrein. Kallikrein is going to convert plasminogen into plasmin, and plasmin is going to dissolve. Plasmin is the opposite of fibrin. Fibrin makes a blood clot. Plasmin dissolves the blood clot. So that is pre-kallikrein. We're gonna go from kallikrein. We're gonna go from plasminogen to plasmin, and then from plasm kallikrein is gonna convert. You see again, plasminogen. Same way we had fibrinogen has been turned into fibrin by thrombin. Here you see the opposite. Plasminogen converted to plasmin by kallikrein. And then plasmin is going to dissolve that fibrin meshwork. You need to remember that diseases are when you make thrombus means you have a big blood clot. That's a thrombus, a very big blood clot. It most likely to occur in the leg and the veins of the inactive people. And a piece may break off and lodge. So pregnant women must get another shot in addition to ROGAM. And what is that shot known as? It's the heparin shot. This heparin shot, because the blood of a pregnant mom is very hypercoagulable. The blood of the pregnant mom is really thick. So the blood of this mom, who is really hypercoagulable and really thick, is going to now cause this thickness is going to make blood clot. Sometimes the blood clot is going to break off and lodge inside the lung, and that's going to kill the mom. And I know a mom who died while she was pregnant. So she died and her baby died because she did not get that shot because her blood became really hypercoagulable. So what's the name of the shot? Heparin, enoxaparin. Enoxaparin. So in order to dissolve it, we use streptokinase, tissue plasminogen activator, and hementin. Okay. Any questions? Any questions? Okay. Please come up and take the labs. Absolutely. If you missed today's quiz, you cannot take it.